the first thing to say about castration-resistant prostate cancer is that today, castration-resistant prostate cancer is a slightly different beast from what it was 5 years ago. And of course, the main thing that's changed there is the fact that we're using additional therapies, particularly additional androgen receptor-targeted therapies in the hormone-sensitive state. And so increasingly, I'm finding in my practice that when a patient becomes castration-resistant for the first time now, they've already had either enzalutamide or abiraterone, or maybe apalutamide or darolutamide now, and they may also have had chemotherapy. So modern day castration resistance actually isn't really castration resistance, it's castration and androgen receptor targeted therapy resistance. And of course, these patients, their therapeutic options are more limited because of that. And of course, the disease is often more aggressive than first purely CRPC. The first challenge we meet there is, well, we would otherwise have treated CRPC with an androgen receptor targeted agent, but we kind of know that if you've already progressed on, say, enzalutamide, the chances of one of the others working is extremely low. And there are lots of trials now that have explored that then as the control arm. But it's very unusual for patients to obtain significant clinical benefit from sequencing one ARTA therapy after another. And so these patients are usually heading towards chemotherapy as their standard option if it's a suitable one for them. But of course, there are other options available now. PSMA lutetium maybe an option for patients who are unsuitable for chemotherapy, for example. Although, of course, there isn't yet widespread access to PSMA lutetium therapy. And the other treatment that may be a consideration is also PARP inhibitors, particularly Olaparib, which of course is licensed in this post-ARTA BRCA patient population. So it's quite important that you early on are getting somatic BRCA testing done for these patients, because if you do have a BRCA mutation, then probably your most effective agent after failure of your ARTA and HSPC will be a PARP inhibitor. Now, there's been a bit of a sort of stramash, as we say in Scotland, in recent years, in the last year, in fact, with the results of a couple of trials which have combined PARP inhibitors, 3 trials which combine PARP inhibitors with ARTA therapies. So there's the PROPEL trial, which is abiraterone in combination with Olaparib. There's the MAGNITUDE trial, which is niraparib in combination with abiraterone. And more recently, the TALAPRO-2 trial, which is talazoparib in combination with enzalutamide. And I think it's fair to say that all 3 of those trials have shown that the combination with a PARP inhibitor is better than the ARTA alone in patients with a BRCA mutation. What's less clear-cut is to what extent other HRD mutations benefit. And maybe more controversially still is that 2 of those trials, the PROPEL and TALAPRO-2 trials, have also shown that patients with no HRD mutation do also appear to benefit from the addition of the PARP inhibitor. Although at this point in follow-up, there's still no confidence that those patients have a survival benefit from that intervention. So these data are already quite complicated, but throw into the mix that those trials were essentially conducted in a population of patients who were castration resistant, but who had not had a prior ARTA therapy. As I've just said, actually, those patients are becoming thinner on the ground. And so it is really unclear in a patient who's already experienced progression on enzalutamide, abiraterone, darolutamide, apalutamide in the HSPC setting. It is unclear whether those patients will or will not benefit from combination ARTA therapy plus a PARP inhibitor, whether or not they have a BRCA HRD or none of those mutations. So I think we still need to find out more information in that niche.